Good evening, everyone. My name is Emil. I'm an interventional cardiologist. I'm the Director of Medical Affairs for Europe, Middle East, and Africa at Boston Scientific. I'm very pleased today to join you here with an expert panel of friends and physicians for our first LAA club, basically. This club was built for you, and in which we are aiming in 4 consecutive sessions that will happen throughout this year to discuss best practices, to introduce you to new concepts in the Watchman space and the LAAC space overall. So very important to note that although this is virtual, the goal is really to hear your opinion, to see your questions. So feel free to ask any question you have to our 3 panelists today. And more importantly, all this will be available later on for you as view on demand to keep sharing this learning experiences. So without further ado, once again, I want to welcome you to the first edition of the LAA Club. With us today, I'm very honored and pleased to welcome Professor Henning Ebelt, Professor Romain Echalier, and Dr. Rodrigo Esteves. And don't forget, keep asking questions, keep connecting with us. I'll pass it to you now, Prof. Ebelt.
So, thank you, Emil, for this kind introduction. Hello, everybody. I'm very honored and pleased that I am allowed to be the first speaker of today's LAAC Club. As you have heard, it's the first edition, and today we want to address the question how we potentially could streamline the procedure of LAA closure. So my talk will not end up with a suggestion how you have to do it in the future. Rather, I would like to show you some ideas and share with you some thoughts how you could perhaps change your procedure. But it's more, we want to start discussion about this topic rather to give a very fixed structure. So before I can tell you how to streamline perhaps the LAA procedure, I would like to explain you how I myself am usually doing it. So before we implant an LAA closure device, we have, of course, pre-implantation imaging. And in our department, we normally use TEE for this. We want to have a TEE which is not older than 3 months. And if the patient is not on oral anticoagulation, we want to have it within 48 hours before the procedure. Alternatively, we have more and more usage also of cardiac CT, but TEE so far is still the standard of care. During the LAA closure, we keep our patients on conscious sedation with propofol and fentanyl. As you perhaps know, in Germany, it's allowed for the cardiologists to do so. So that means we do not need a special anesthesia team, which of course is different in other countries. And we guide our procedure by TEE and fluoroscopy. And I myself rather usually use fusion imaging. I'm going to talk about that later on, show you a few slides regarding this. In the post-implant phase, we keep the patients on dual antiplatelets for 3 months, followed by aspirin for a 1 year minimum. And we only have one follow-up imaging, which is after 3 months, a TEE or CT. So with my next slides, I would like to show you some ideas how we potentially could streamline LAA closures. And one thing that I personally consider to be rather important is that we should try to avoid the inadequate postponing or cancellation of procedures which have already been scheduled. And in my hands, it turned out that especially in the pre-implantation phase, the use of ultrasound contrast agent during TEE is very important and very useful to improve the rule out of thrombi. And we have investigated this with a clinical trial, a clinical study, CONDRA study, where we have performed 223 TEEs, which were first carried out without ultrasound contrast agent, and then afterwards in the same patient repeated with the use of ultrasound contrast agent. And what we found out is this, especially the number of inconclusive results where we were not sure whether or not the patient had a thrombus could be significantly reduced by the use of the contrast agent. So we had a higher percentage of patients where we finally were pretty sure that there was no thrombus in the LAA. And this in turn led to the fact that we could reduce the number of procedures which otherwise would have been postponed by 38%. That means a much higher percentage of procedures that were originally scheduled could finally also be performed. And this, of course, is resource-sparing and a good thing in my eyes. Beside this, another way how to streamline LAA closure, of course, could be to use improved intraprocedural imaging. And as I have mentioned before, at my department, we regularly use fusion imaging of TOE and fluoroscopy. And this combination helps us especially during transeptal puncture and, of course, for the positioning of the occluder. And I want to very briefly explain you how we are doing that. And again, also the procedure of fusion imaging is very lean in our hands. So initially, when we start the procedure, we start the image fusion by co-registration of angiography and TEE. That means that our hardware has an automatic probe detection algorithm, which is integrated into the fluoroscopy setup. And then we can put marks in the TEE. For instance, we mark the fossa ovalis, which is then also shown on the fluoroscopy. And we put a second circle on the LAA ostium, which you can see here then and on fluoroscopy as circle 2. And this is all we mark for our procedure. And this helps us to find the best way of transeptal puncture. But even more important in the end, we can use fusion imaging to find optimal patient-specific C-arm angulation of the fluoroscopy so that we can adjust our C-arm, that this circle, number 2, then turns to a line. That means we have a perfect orthogonal projection of the LAA ostium, and that allows us to put the device exactly at the position where we want to have it. And we use, in this regard, the fusion imaging for the positioning of the device, and we check the position before the final release. Another study in this regard has shown in our hands that indeed this use of fusion imaging of TOE and fluoroscopy reduces the time of the procedure by approximately 15 minutes. This was a retrospective trial of 50 conventional cases in comparison to 25 cases performed with FI. And as you can see, not only procedure time was speed up to 30 minutes, but in parallel, also the amount of contrast volume that we were using went down. So we had 2 positive effects arising from fusion imaging. So the third and last idea of possibilities how to streamline LAAC is that, of course, it would be great if we could try to get rid of general anesthesia or even sedation at the cath lab, because this, of course, is a factor that always might cause some delays. And one way, of course, would be to use ICE instead of TEE, or to use micro TEE. And I know that we're going to hear about that later on today. But another way also would be to use neither TEE nor ICE, but perform a fluoroscopy only LAA closure. And this should be possible, especially if you have a CT-based pre-planning of the procedure. And Again, we have done a kind of feasibility study, FluoroFlex study, where we have included 31 consecutive patients that were scheduled for LAA closure with the Watchman flags. And as a pre-implant imaging, we did a CT, first to rule out thrombi, second to determine the size of the LAA for the selection of the occluder size, and very important also to determine the optimal C-arm angulations for the fluoroscopy during the procedure. Within this study, TEE was performed only for safety reasons. This means that the images were not available for the implanting physician, but only checked in the background by the echo physician. And we had 3 protocol-defined checkpoints, which had to be confirmed by the echo physician during the procedure before the interventionist was allowed to go on with the LAA closure. And indeed, we found that in these 31 patients, TOE did not have an impact on the procedure. That means the findings of the TEE did not influence the procedure. So we had a pre-specified non-inferiority margin in our study and could say that the only fluoroscopy or fluoroscopy only LAA closure was non-inferior to an TOE-guided procedure. However, during our study, we realized that initially the amount of contrast medium that we were using went a bit up. So we switched during the study from a monoplane to a biplane implantation strategy, and that indeed reduced the amount of contrast medium that we were using in the end to normal values. So let me summarize these some ideas that I have shown you. I think due to the advantages in technology and occluder design and so on, there are multiple possibilities how to streamline LAAC procedures today. I think they are very much depending on local circumstances, starting with legal issues, but also limited by equipment and so on. I believe that the use of imaging is of central importance if you want to speed up LAAC procedures and streamline the procedure. But of course, we can use some of the advantages of the Watchman flags, especially its atraumatic positioning, easy recapturing, and the easily seen fluoroscopic markers, etc. Beside the procedure itself, of course, we can also make the follow-up easier simply by adjusting our follow-up strategies. So thank you for your attention. And I hope I could give you some ideas and some thoughts how we could adjust our LAA closures. And I'm happy to hear your comments.
I think this was fantastic. Truly, what a great opening for this club, really, setting the bar very high. Was clear demonstration, your approach to the lean pathway. Maybe before we move, and again, I encourage people watching us here to ask questions. I want to ask Rodrigo and Romain, you've seen how Henning is doing it. Tell us maybe briefly, any major differences or any subtle comments on how he presented, or things that you think you want to maybe shed more light on while we wait for more questions from the public here.
Okay, if I can take the first word. I fully agree with Professor Ebel that if you want to do a large LAA occlusion program, you need to make procedure like as much as minimalistic possible. The greatest change that we observed in our program was 2 points. First point is start to doing CT to all patients possible, because this allows us to perfectly know the sizing, the type of LAA, the anatomy, the fine-tuning of extra lobes, position of the Marshall ligament. So you have all the information beforehand before going to the cath lab. And then in the cath lab, be as much as minimalistic possible. And the other change that I have to point out is the start of doing like 95% of our cases with the micro TE on cautious sedation. Because since you have all the information from the CT anatomically and sizing, the micro T only allows you to be in the safe part of the procedure, doing correctly the transeptal puncture, and then you can follow most of the procedure by the fluoroscopy, since you have all the information from the CT. And this is one of the major changes that we have introduced in our program to raise our numbers.
Thank you. Great comment, Rodrigo. Roma, the French way, is it different or about the same?
It's a little bit different, but I totally agree that the fact that if you want to develop a lot LAA occlusion, it's important to have a good protocol and to be a specialist. I think that, and I will discuss after in my presentation, that in France we have older and sicker patients that you may have in Germany or in Spain. So we use less CT scan because we have a lot of chronic kidney disease. And for example, in the population I will present to you, we only use CT in around 50% of the patients, and we try to not inject iode in the majority of our patients. And we only do thanks to the micro TEE.
So again, we're looking forward to hear more. I know about micro TE later in the program, but let's continue, move on. Again, we'll have plenty of further discussion. I'll pass it to you, Romain. I know you prepared a case for us from your practice. So I'll pass it to you, and maybe you can tell us, share a bit the case, and we'll have further discussion down the road.
Thanks a lot. And good evening, everybody. I'm Romain Charlier from France in Clermont-Ferrand. It's a great honor for me to be here and to discuss with you. So as discussed before, I will introduce a clinical case just to remember, because we asked me to remember you the guidelines. As you know, since 2016, the guidelines and it was confirmed in 2020, allowed to perform LAA occlusion in Europe if you have a contraindication to anticoagulant therapy in patients with AFib. In the last era consensus experts, they are more optimistic, and they say that we should do this technique and this procedure in the same patient. So we have a higher grade of consideration for this technique. In France, it's more difficult, as usual in Europe. We are a little bit late, and the guidelines in France to perform left atrial appendage occlusion allow us only if we have a CHA2DS2-VASc score at 4 and a definitive anticoagulation therapy contraindication decided and validated in a dedicated multidisciplinary staff. That's the first 300 patients we performed under, others will explain to you, traditional methods with general anesthesia and 3D TEE. As you can see, we have the majority of male with an age of near 80 years old, with 35% of the patient with an history of heart failure. And we have a majority of permanent AFib, and the mean CHA2DS2-VASc score was around 5. The main etiologies of definitive contraindication to anticoagulant therapy were in our population, and it was the same in France, where neurological and intestinal bleeding contraindication. And we have a big change in our practice here in our Clermont-Ferrand, thanks, if I could say that, to the SARS-CoV pandemic. Since during the first lockdown, we have to stop all our procedure as recommended by the French Society of Cardiology. And they say that if we should not perform any left atrial appendage occlusion, and that was quite similar in the US. So thanks to the COVID and the first lockdown pandemic, we moved to the traditional method, as I said, under the 3D-TEE, general anesthesia, and we performed 3 patients during 6 hours, and we moved to, from our point of view, an innovative methods, especially in France, with micro-TEE, conscious sedation, and we performed around 6 patients during 5 to 6 hours. So the case I want to discuss with you today was performed yesterday morning. It was a wife, 79 years old, with an orphan disease, a Chagas-Vasco at 4, and the contraindication for anticoagulant therapy was an intestinal bleeding with no opportunities for our colleagues to treat it and complicated by anemia. She was in permanent atrial fibrillation. As previously discussed before, our pre-implant strategy was performed during around 30 to 60 days before the procedure with our multidisciplinary staff. I see and I met all the patients before to explain well the procedure, to be sure that there is no contraindication. They also see, because in France we cannot use propofol or fentanyl, they all see and met the anesthesiologist, and we performed, as I said before, in around 50% of the patient, CT in many cases, in the majority of the cases, 1 day before the left atrial appendage occlusion procedure. We use, of course, as you probably know, Trimencio, and this is the CT of our patient with a chicken wings LAAC. But we think that we have a good opportunity to implant before the curve. That's the French guidelines for our cath lab to perform an LAAC occlusion in good conditions. We only could perform this procedure in an hospital with cardiac surgery in the same building. We have to use transesophageal echo and fluoro. We have to perform ACT during the procedure. We need to be 2 cardiologists, 2 interventional or EP cardiologists during the procedure, 1 echo, 1 anesthesiologist, and 2 nurses. And they ask at the beginning that we have to perform at least 25 LAAC occlusion per year to be validated in our center. Emile, if you want, we can cut here and discuss.
Definitely several points for discussion, and it's always interesting to see like how different countries can be and practices can be and guidelines can be. But before, and I'm pretty sure, I think Rodrigo might have comments, we'll take the questions. We promise to take the questions from the floor. We have 2 questions here. The first one, and I'm pretty sure it will be addressed at some point, but because you mentioned imaging, one is, how is the quality of the micro-TEE if you compare it to ICE? We have nowadays also the 4D ICE catheter on AcuNav, which can be an optimal option. What are your thoughts, before maybe you show us images and practice on this specific? Anyone can take it.
To be honest, I have never used ICE because in France it's very expensive, more than 2,500 euros with no reimbursement, so we do not use it. So I don't know if my colleagues have this experience, but I have not.
We have some short experience with ICE. I know that in the US, for instance, there's a large series of doctors doing ICE because they have some issues with, it's different system. They have some issues with the imaging or with the pre-planning CT because maybe sometimes it's not covered and so forth. But I think in our country, in Spain, most of people still rely on transesophageal echo. The main advantage of the micro TE is that it's really friendly to operators. I mean, you are used to the same views. So at the end, you've learned this beforehand for other procedures, for mitral clip or different procedures. So you are very used to the views and you feel it really in the safe part. I have to say that the quality of the imaging is much worse than the standard transesophageal echo probe, and you don't have the 3D, at least now. It's probably under development a new probe with 3D micro TE that could improve a little bit the imaging. So if you want to go for micro TE in all patients, you need beforehand a very good pre-planning imaging or CT or 3D TE to do it. And for instance, you have this difference, it's called mini TE, that is different from micro, that has already 3D and you have a better view. So probably maybe in the future, the micro TE with the improvement of the 3D imaging or the mini TE that is also well tolerated could do the job.
Excellent. Maybe I'll direct this next question maybe to Henning. We have a question. Someone is saying we're very comfortable with the transseptal puncture thanks to the volume of mitral valvuloplasty. Is the technique of the transseptal puncture in the LAAC different? Thus, what are the tips to get to improve that LAAC procedure where we don't have fluoroscopy fusion process? Can you give us some tips on that?
Yes, thank you for this question. Of course, you do not need fusion imaging to do a good LAA closure procedure. If you are experienced with transseptal puncture, you won't need that technology. I think the main advantage of the fusion imaging is really that you can select and determine optimal C-arm angulation of your fluoroscopy. I don't know how you are normally doing that, but when I'm implanting LAA closures without fusion imaging, I always choose an RAO caudal because I presume that this would be the optimal projection to get a good view on the ostium. However, if you combine it with fusion imaging, you will finally notice that this is not always really the best projection. And especially if things turn out to be complicated, you might need a second projection if you do it in a conventional way. And this is the advantage if you have fusion imaging, that you really have patient-specific optimal imaging. So my tip, and I guess you know that already, if you have you won't need much more equipment for transseptal puncture. But if you have the impression that your anatomy of the LAA is somewhat complicated and you are not very sure where you want to land with your device or things looks a bit difficult, very simple tip, take a second angiography of the LAA, take a second projection. I personally always switch to an RAO cranial. But from my experience with CT pre-planning and also fusion imaging, sometimes also an LAO caudal projection can be very helpful, especially if you have an unusual angulation of the LAA. So taken together, very simple tip. If things are difficult, take at least a second projection.
Fantastic, thank you. Maybe the third question before we go back to Romain, and I want to hear you because this can be a transition because it's a very broad question, but really difficult LAA in imaging, how to manage them. That's a broad question, I know, but any tips or recommendation, that's always, the struggle, even from simple transthoracic echo, you always have this patient, you can get echo. You're talking, or any procedure. Any tips when you're having difficulty imaging that LAA, and maybe from that transition, you saw the case that Romain just showed us. Anything you want to comment on that before we pass it back to him? We can take Rodrigo, then maybe Henning.
In my view, if you have a difficult LAA imaging on TEE, that is, I mean, when you start your program, most centers start with TEE, then there's with definitely, I fully agree with Henning that CT scan and fusion can help you to understand exactly the anatomy, the way, the place do you want to do the transeptal puncture, because usually we do it inferior, posterior, but sometimes if there's some funny anatomies, you want to be a little bit more anterior, just to make you easy to land in a nice place, let's say a chicken wing with a huge angulation. So in those cases where CT and fusion probably gives you all the information, as that's really in those cases when it's really helpful and recommended.
Yes, I completely agree on that. And I just want to add one very small hint. Probably you know that, but if you are performing a procedure based on TE and it's really difficult to get good TE image, simply try to put your patient a few degrees to the left side, as you normally do it for a routine TE. And even if it's hard to believe, but sometimes a few degrees moving to the left side are of great help. So if you have problems with image quality of TE, please try this.
Fantastic, excellent tips, I think, and a great discussion. Roma, I know you started the case. We interrupted you with very valid questions coming from the audience. We want to pass it back to you to see how you address this patient, basically.
Thanks a lot, Emil. It's my pleasure to introduce you my team and the LAAO team with another specialist on congenitalist cardiologist. And here we have my two echographists. We are, I think, from my point of view, very tough echographists. Here our cath lab. So we work in our EP cath lab. So as I said, we are two interventional cardiologists, one echographist, two cardiological nurses, and we have one anesthesiologist and one anesthesiological nurse. Of course, we are not crazy, and we, of course, want to be efficient and safe for our patients. At least that our patients are quite old. So we use, as said, Rodrigo micro-ATEO. We performed all our procedure and under this strategy with micro-TE and conscious sedation. We performed just in the bedroom midazolam, and after we use remifentanil propofol with local anesthesia, where we are performing the venous puncture, and at the end of the procedure, they start paracetamol. To be sure, and sometimes we have some difficult images with micro-TE, so we perform every time before we start a subxiphoidal TTE to be sure that we do not have any pericardial effusion before we start. After, when we are planning the procedure and we are starting to make the table with my colleague, my echographist is performed all the measurement at these different views. And in these cases of the patient, we confirmed with the CT scan that we can use a 27 millimeters flex devices. Another time, to be sure that we are safe, we always start with echo-guided venous puncture. We have no fusion in my center, but thanks to the CT and the micro-TE with a good experience, we know that when we want to be sure that we have no left atrial appendage thrombus, of course. And the first important step is to perform a good transeptal puncture. For this puncture, we use we always use the radiofrequency Baylis needle, which help to keep the right position and in the majority of the cases, we try to keep a posterior inferior position. And when we are quite delighted with the position, we use the radiofrequency system. So in around, I don't know, 30 to 40% of the procedure, we do not have to use the radiofrequency, but the needle is more stable from our point of view. And as you know, Wenkel in 2011 published this study showing that the greatest opportunity to decrease the rate of pericardial tamponade after a transseptal puncture was the use of a radiofrequency needle compared to a standard needle. After our transseptal puncture, we another time perform the subclavian TTE to be sure that we do not have any pericardial effusion, and after we perform an heparin bolus. To remember, this patient was around 60 kilograms, so we only perform a 4,000 heparin unity. Thanks to the micro TTE, we know that we are with the ball in the left atrial appendage, and you can see here that I use a combined strategy to implant the flex with a quite good aspect and morphology on the fluoro. My colleague is performed a complete turnover around all the device in all the different degrees. And you can see that here in 50 and 90 degrees, we have a quite good aspect and a good position of the flex. So we were quite happy, but at the 135 degree view, we found that there is a too important part of the device in the left atrium. So we decided to retract the device. We decided to go a little bit longer and further and in a more distal position in the left atrial appendage. And I changed also the way I deliver the device with only an advance of the ball and of the sheet. And as you can see, if we compare with the first position, the device is a little bit in a more distal position, and here with all the different views in 50 or 60, 100 and 135 or 150 degrees, there is a good aspect with a less important part of the device in the left atrium. Before we decided to release the delivery system and to leave the device, of course, you need to check a lot of information before. You have to be sure that you have a good compression. Of course, you have an idea thanks to the fluoro to see that if there is a good compression, but we also perform in all the different views thanks to the micro TEE, and in these cases we have around 25% compression for this device. So we were quite happy. After we performed the 10 seconds pressure on the device, and we finished our final check with a tuck test, which here is clearly positive. Since we are confident with the position of the device, we have decided to release the delivery system and to leave the device. And as you can see, there is no mobilization of the flex after we release the delivery system. And that's the final micro TE with a good position and with not an important part of the device in the left atrial. And to finish our procedure, another time, we perform a subxiphoidian, TTE, to be sure that we have no pericardial effusion. We performed an artisanal cutaneous closure. The patient kept comprehensive bandage until the 8 a.m. at day 1. We all follow our patient thanks to 24 hours ECG monitoring in our classical cardiological department. We only perform a preventive enoxaparin. And since our patients are a lot of frailty and a true contraindication of anticoagulant therapy, we only use aspirin for 75 milligrams with no DAPT, with no anticoagulant therapy, and the patient lives at day 1 our department. We know that that's not the true and the guidelines for the anticoagulant or antiplatelet therapies that we use, but we are conducting meta-analysis concerning this project, and we have also data published from other French centers, and we know that, and I will show you our local data, that there is no increase in systemic embolic or hemorrhage after when we only use aspirin. Another time for the follow-up, we have clear guidelines in France. They ask us to see and to meet our patients in a face-to-face consultation with a clinical follow-up at 3 and 12 months after the procedure. We performed, of course, a TTE follow-up, but we only use CT at 3 months in many of our patients. We have decided not to perform TEE for this patient, for this frail patient, because it's quite hard for them. And that's our data with 2 periods. As I said, the traditional period before the first lockdown, and what we have decided to use and our new strategy since the second lockdown with conscious sedation and micro-TEE. As you can see, there is no difference in the general characteristic of the patient, except that in the micro-TEE group, we have a more important part of patient with an history of heart failure and a more important Hasblet score in the first group. As I said before, only 50% of the patient had CT before micro-TEE. We use injection during the procedure only at least in less than 5% of the patients. And when we compare these 2 groups, we show that there is no difference in our first composite primary endpoints, that during the first 3 months, we have no more stroke, no more pericardial effusion, no more change in device size, no more vascular complication, and no more hospitalization at 3 months in the micro-TEE group. So we are safe. And we have, in the same time, a significant decrease in the procedure times, fluoro time, use of injection products, and also hospital length of stay. We decrease by more than 1 day the length of stay of our patients. So to conclude this case and this strategy, my team and I are confident that the fact that this strategy is a promising strategy, we are safe from our point of view, we are effective, but I totally agree that you need a lot of experience before starting in that strategy. Of course, we need more data to be, and a randomized trial to confirm what we observed. And thanks to all the studies with ongoing inclusion, but also the last data from Prague 17, I think that this strategy is safe and effective to answer to the development of left atrial appendage occlusion and the explosion of this procedure in the next years. Thanks a lot.
Thank you, Roman. This was really key and interesting. Thank you for sharing first the experience from your center. It's also impressive to see how you adapted, like before the pandemic, during, and with the first batch, and how you came, as well as showing really the importance of all the team members, from your echocardiographer to your implanter and to your colleague. Maybe I'll ask a quick comment, micro TE, constant sedation, before I take two quick questions, but maybe Abel, Henning, do you want to add anything on what Romain and his technique, or any comments?
Yeah, thank you. First of all, Roman, thanks a lot for this very interesting case. And actually, I have a number of comments that I would like to ask you, because it's always very interesting to see how people are doing things differently. Because there are also a lot of questions from the audience, just one brief comment from me. I think conscious sedation is certainly something that works pretty well in LAA closure, and I completely agree that it makes things easier. Even if we perform normal TE, we use this conscious sedation. I think it's perhaps as one advice to people who switch from general anesthesia to conscious sedation, it's a bit more important perhaps to make sure, from my point of view, that the patient that we are a bit more careful regarding air embolism, because if the patient is breathing spontaneously and has no positive pressure ventilation, then the risk of air embolism is a little bit higher than that. I think we should keep that in mind. But if you have an experienced team and enough people in the room who are caring for the patient, then it's pretty safe. And yeah, it was nice to see how you can do it with this very tiny TE probe. So looks very promising for me. Thank you.
Yes, thanks a lot. I totally agree with you. And as said Rodrigo a few minutes before, we hope that we may have the 3D on micro TE, and of course we will have better imaging and it will be more comfortable for us. But of course, when we start with this new strategy, the first 5 to 10 cases were performed under general anesthesia to have a good experience with micro TE imaging, because at the beginning you see thrombus everywhere with micro TE. So the two first micro TE procedure, we moved to a normal TE to be sure that it was not thrombus, and after we have improved our knowledge of the image thanks to micro TE.
Great. Maybe we want to be cognizant of time of the people participating at this late time. We'll take very quickly a couple of questions and then we pass to Rodrigo's talk. But one question from the audience: how do you obtain the ideal implantic projection on pre-procedure CT scan? Do you start by identifying the landing plane, LAA, ostium? Anyone wants to give maybe some tips on that? I know you covered it en passant also.
We are really based on CT, most of our cases. You can do it with whichever program you have for analyzing the CTs. For reconstructing, you can do it with Remension. You can do it with R Navigator from Philips as well. The starting point is to delineate the LAA volume. And once you have the LAA volume, you can put markers on the ostium, on the landing zone, and then you can rotate. There's a tool that you can rotate your C-arm to see those lines and markers that you have set before to be perfectly in plane with the perpendicular plane that you want to see in your C-arm. And this is, you have to read in the automatic tool the projection exactly. Usually, as Professor Henning said before, it sometimes is areocaudal, that is the most of times, but sometimes in some funny LAAs, if you have rotation of the heart, you have to go apicaudal or a little bit aleo sometimes. So it gives you a little bit more info.
Great. We have 2-3 questions, but I know, Rodrigo, there is a lot that you might cover in your talk. We have questions on the safety of aspirin and the safety of doing the procedure in centers without cardiac support. So without further ado, I'll pass it maybe to tell us a bit about the clinical data, and then we'll make sure if some questions are not covered in your talk, we'll try to ask them toward the end in the final comments.
Sure. I sharing my screen. Hope you can see it. Yes, I
Yep,
try to
perfect.
go. Yeah, I know we are running a little bit out of time, and we have a lot of questions. Try to go give some clear messages about this new technology that is Watchman Flex. That is for me is a huge change compared to the 2.5. You all people that is joining us know in the last years we have changed from the Watchman 2.5 to Watchman Flex to increase flexibility of the device, control of the implantation, and to increase the sealing of the LAA and the healing of the device, try to improve the DRT rate. We have several features that have improved. Probably the main, the most interesting ones are that we can create a soft ball that we can navigate in the LAA that is automatic. The anchoring system has improved, and now we have something that is really safe to navigate and to increase the sealing of the LAA. We have increased as well the range of the length of the LAAs that we can close. And as I mentioned before, this ball configuration is really safe to navigate. It's easy to retract as well the device and re-implant without creating any damage. So most of information about this device is coming from two registries. One is the US registry, it's called the Pinnacle Flex. They were 400 patients. And then we have one European one that is the Flexibility Registry, that are 300 patients. And we have very good information. It's really analyzed the data in this device. The main messages from the Watchman Flex taken from these two registries are the following. First, it's a really safe procedure. Watchman Flex has increased really the safety of the procedure. In the Pinnacle Flex, only 2 cases in 400 of ischemic stroke in the first 7 days, and one of them, the device was not even implanted, and this is significantly below the performance goal that was set for this registry. And it's importantly, no deaths, no pericardial effusion requiring cardiac surgery, no device embolization. This was replicated as well in the Flexibility Registry with only 1% of pericardial effusion and very low rates of DRT and adverse events related to the device. So compared to the prior 2.5 Watchman, we can see a clearly difference in the safety part of the Watchman Flex. And this is a huge advance in doing these procedures because, as you know, it's a LAA occlusion is a preventive procedure, so complications are not allowed, and this can be really done really easy with the Watchman Flex device. Another important data comes from this recently presented trial that is the Swiss APERO trial that was several centers in Europe. They randomized to Watchman and mainly Watchman Flex compared to AMOLED. Endpoint was something about LAA patency, but what was important in this study and supports what I said before is that Watchman Flex is safer than the competitor, at least in this study, during the performance of the procedure. And this is an important message because as we are doing more and more minimalistic procedures, we are working as well to increase our numbers in the same day discharge protocols. I mean, we do this in our hospital sometimes in some selected patients. It depends, of course, on your seriousness and your frailty, your age. But whenever it's possible, we try to go for same-day discharge, and this can be done supported by the Watchman Flex safety performance that has been improved, as I said before. Another important part of the device is not only safety, but is the success. Is really high the procedural success. The Watchman Flex in the Watchman family and the Watchman studies has the highest procedural success. And this success is, apart from that you can implant the device, the most important part is that you seal the LAA in almost 100% of the cases. And this was seen both in Pinnacle Flex and both in Flexibility, with no cases of peri-device leak greater than 5 millimeters. So this is another important message. The sealing is really important. And Another interesting study that was presented recently, I guess, in DCT was a comparison between Watchman Flex and Amulet device. And supporting this concept of improved sealing, we observed that Watchman Flex was superior to Amulet as a complete occlusion detected by CT at 8 weeks. And there were less leaks, and the size of the leak was smaller in the Watchman Flex. So this supports again the concept that the sealing with this device is improved compared with the competitor. Another important part is the healing. The healing is closely related to the DRT. In the Pinnacle Flex, only 1.8% of DRT at 2 years. And this is quite important because from these 7 patients with DRT, clinically strokes were seen only in 2 patients, 2 out of 395. That is really very little clinical impact in the patient. So again, the healing of the devices as well, another important message. We can compare, and Watchman 2.5 was compared to Watchman Flex in this Ulster Flex registry, that they compare a series of patients treated with Watchman Flex with patients from the evolution. And although the clinical endpoints were not statistically significant, we can see a tendency to less device-associated thrombosis and a significant, more complete sealing with the Watchman Flex. So this supports all these features that I mentioned before. Just to finish, and as Romain mentioned before, we have seen now the presentation of the PRAX 17, where although there were no significant differences between the 2 arms, we see that over time the curves start to diverge, and it seems to favor LAA occlusion. And in this line, just to remind you that we have the CHAMPION-AF trial, where Watchman Flex will compare head-to-head to novel anticoagulants, and we strongly try to push people to include patients in this trial because it will be really meaningful for the therapy and for the patients in the next year. This is how will be the randomization, and hopefully before the end of this year, all the patients will be recruited. And this is all I wanted to share with you. And of course, we are happy to take some questions.
Thank you. This was true tour de force, really. In I think in 7 minutes, you took us through the big bulk of the data, and that's fantastic. And I'll start by echoing what you just said on CHAMPION-AF, because that is the type of trial that can potentially change guidelines, you know. So I see here thumbs up coming from Henning. I want to ask, because want to make sure we cover all the questions. We'll be very brief because you mentioned a lot on whether the thrombosis rate, all these, but let's ask a very simple one. One question came on the cardiac center availability on site. Basically, do you think how safe it is to do it when you don't have cardiac surgery on site? I know it's country specific, but maybe Henning, you want to address that issue about cardiac surgery backup, whether on site or a nearby hub?
Yes. So thank you for that question. I think that's very important to answer that. Well, I have a very clear opinion on that topic. I'm pretty sure that you do not need cardiac surgery on site. Of course, it's always nice to have our friends from cardiac surgery as close as we can, but especially for the LAA closure, we really don't need them. I mean, what kind of complications do we have to be aware of? This is first of all, of course, some cardiac tamponade, which might happen. If you are doing a lot of cases, sometimes you will have a cardiac tamponade. And I think this can be managed by catheter intervention, by drainage. We will not need a cardiac surgeon for that. And actually, I cannot imagine any complication where you really need urgent cardiac surgery, even if you have a device embolism, which is such a rare event today. Even that you can retrieve the device with a snare or something like that. And if it doesn't work, you will have enough time to bring the patient to a cardiac surgery center. So taken together, I'm perfectly sure that you do not need cardiac surgery on site. And also in Germany, it's not a prerequisite to start a program.
Excellent, thank you. Maybe my last question would be to Romain, and maybe if I'll comment to Rodrigo before maybe you close any. Romain, there are questions. Did you analyze the data on just aspirin in your practice? You know, there is a lot of questions you probably saw coming on aspirin and the regimen and the risk of the device-related thrombosis. Maybe if I'll comment on that.
Yeah. Our rate of device-related thrombus was less than 2% at 1 year. We have around 1.5% with only aspirin.
Excellent. That's as clear as it can be, basically. Rodrigo, any final comment?
Well, regarding this medication after LAA, I think there's a lot of variation because, as Romain mentioned before, there's different types of population that they're doing. I mean, they're doing really frail patients with contraindication clear for anticoagulation. So in those patients, probably you should go only for one antiplatelet agent because otherwise the bleeding risk is so high. But as you broaden the spectrum of these patients, now I'm thinking in our center, we are doing more and more patients with recurrent stroke under NOACs. That's, I think, it's a big thing that will come in the next years. And I think in those patients that they don't have contraindication for anticoagulation, probably LAA closure on top of the anticoagulation, it gives really further protection for stroke recurrence. So I think you have to tailor a little bit with the type of patient.
Excellent, excellent.
I completely agree with Rodrigo. We do the same in France when we add left atrial appendage occlusion on top of anticoagulant therapy in recurrent stroke. Of course, we continue anticoagulant therapy. And I'm convinced that in younger patients with less frailty, that we will include in Champion AF or something like that, or this trial, and in first position of left atrial appendage in the next year, I'm convinced that we do not leave them only under aspirin. I do that because my patients are very frail.
Excellent, excellent. Thank you. And with this, before I pass it for maybe the closing comment and the final learning, I want to thank you all. I personally learned a lot, and mostly from this sharing of practices in this first edition of our LAA Club. And as I said in the beginning, this can be viewed 48 hours. You can just go to the LAA Club platform and you can see it, view on demand, review everything we expose. Stay tuned for edition 2, 3, and 4 that will come throughout the year. This is, again, I want to finish by thanking you, Professor Henning Ebelt, Professor Romain Escalier, Dr. Rodrigo Esteves, and also the silent colleagues that really do a lot of work, Vincent Willems, Elisa Vereka, Pier Paolo Llosa. And with that, Professor Ebelt, I'll pass it to you maybe for the final comment, and thanks again for all of you.
Yes, thank you. It's a bit sad for me to close the session today because it was a great fun to hear your ideas, and it's always so interesting to see how people are doing similar things a bit differently. Unfortunately, I think that's all what we have on time for today. Nevertheless, I hope you all enjoyed this session. Again, also from me, thanks a lot to the faculty, Romain, Rodrigo, thanks a lot. Thanks to the help of InCathLab for organizing the session. And of course, also thanks to Boston Scientific for their support in setting up the LAA Club. As you have already heard, you can review this session online. Please register at the website LAA Club, also to make sure that you receive information about future sessions, which are planned for June, September, and November. Yes, thanks to all of you, and we are all looking forward to see you again. Thanks, bye-bye.